Okay, I guess we'll get right started. Is Nicole in here? Maybe she can help me out. I don't know what we did last time. Can everyone hear me okay? Okay, good. Matthew, I'll give you a general uh, answer to that. How much Subutex are you on, if you don't mind me asking on here? Yeah, Matthew, the taper method really depends on how long you've been on it, what dose you're on, what was the reason you got on it, and where you are at in your long term recovery, taking into consideration uh, 24 milligrams 3 times a day, uh, one in the morning, after, and night. So it really depends, again. So, what was the substance you were on before? How long were you on that? How has this been going? Are you in a place where you have other markers of recovery that are clear as day? What are some of those markers? The way your brain's working, your behavior, your growth in social areas in terms of other drugs, in terms of job, in terms of making your appointments. And then at that point, if everything, and guys, the ones that just came on, hey, Misty, guy, ones who just came on, Matthew was asking about, he's on 8 milligrams of Subutex 3 times a day. And he just simply asked, what's the best way to get off? So I told him it really depends on the individual patient, how long, what drugs you were on, how long you were on it, how long you've been on this medication. In addition, is all the other psychosocial markers in place, and you want to begin that discussion with uh, been on for 3 months. 3 months ago is when you started. Yeah, you would have to be on it quite a while if you were. Yeah, I see, Matthew. I don't know, Matthew, your details, but I will say this. I wouldn't be on a major rush to get off of it. Maybe you can have a discussion with your physician about tapering down the dose a little bit. You probably don't need 24 milligrams, but I would consider tapering it down a little bit and being stable for several months at least. And again, I don't know enough of a history of your addictive behavior and potential. And then at that point, if everything is right and I want to consider a taper with the patient, I take it very slow and I let them drive the bus, and I make sure they know that, hey, if we need to go back up, that's okay. And I do something like, okay, which is the dose that you need the least? Okay, maybe cut that 8 milligrams to 6 or 4. Let's do that for a couple of weeks, how that goes. Remember, in my opinion, even if benefit and the alternative of relapse, and sometimes I see some of these guys around here really go hard at other drugs. Might be alcohol, it might be benzos, it might be meth. So my general advice is, hi, Mark, how are you? Good to see you. Hey, there's Nicole. Maybe she can help me out here. My general advice would be don't be in such a rush to come off, Matthew, and make sure your physician understands where you're at. I hope that helps. I wanted off ramp. When should I cut my dose? He said, and I explained to them what the clinical outcome may look like, how long they may be looking at it at my best. The time is not right. And I always tell patients, and this one's a little tough pill to swallow. There are some people, if you go to a methadone clinic, all the steps in methadone is imposed for a taper, whether long term or short term. But there are many that have to be on it for life. I think a lot less than are on it because you have to medically, but same with the subs. Some people have to be on it quite a long time. So I hope that helps a little bit, Matthew. Uh, there was someone asking about tramadol, and I think not good to see you, Mark. Hi, Camila. Tramadol, Camila. Hi, Dr. B. Coming off tramadol, which is Altram, 37.5 milligrams. Not sure. Any advice on 1 year, 5 tabs a day? What does that last part mean, Camilla? You've gone up to 5 milligrams? Oh, you're taking 5. Oh, so you want to taper off? Okay. I don't know what you were on it for, and was it for pain, or were you really kind of abusing them? You have to give me a little bit more, and I'll give you the best advice I can without medical advice. I want to know a little bit more about why you're on the tramadol and how long you've been on it, if that's okay with you sharing it here. Uh, yes, Misty, you do need a therapist. Okay, Nicole. Yes, I think that is important. Once you're on this medication, Mark points it out, you should really, now you're allowing your frontal cortex and midbrain to work. And it's really the property of the agonist antagonist property of this medication, and the long-term property of it as well, which is the same with methadone, except it doesn't have that agonist antagonist benefit. And I think Mark is right. I would start working on the behavior, and that's going to translate into frontal cortex connection changes with the midbrain. And at that point, you're ready to really think about getting off. But I don't know your particular case. But Mark is right about that. Nick, I just asked a good question. What's the question, Chicago? This is too much for me again. Hunter. I hope everyone can hear me in the right way. Okay, Nicole, if I'm falling off, jump on here and help me so I can answer these. I can't see this. Okay, give me 1 second. Let me make sure everything's. Sorry, guys. Give me 1 second. I'm trying to get this. Is that lag fixed? You guys are just hammering me. All right, let me get through these. Chicago Dave asked me again. It says the truth, and then Mark referred to Nick. Uh, uh, any kind of withdrawal, the body attempts to maintain homeostasis. Okay, and when you substance, there is a residual counter produce that has an unopposed effect, and that's how you get withdrawal symptoms. Okay, and these have to do with a whole set of receptors, and in opiate receptors, the central ones are nucleus accumbens and the ventral tegmental area. I don't want to get too hung up on this, but it's a drug. It allows what they call unopposed regulatory effect by counter-regulatory transmitters. I hope real quick, but I hope that helps. Okay, let me move quickly. Sarah Ford, I've been on 8 milligrams of Suboxone for a year, and my doctor is already talking about in the next few years pulling me off. I was a pain pill. Again, Sarah, I don't know your particular case, but if you were using for 30 years and there's no other additional circumstances that I don't see what the rush is in getting you off. But he said in the next few years. So ride with it, talk to him about it, have a discussion. Maybe you need to be on it for life, but don't panic. He said the next few years. He didn't say this next month. Okay, so don't know because I have to see you. I really simply go by people's symptoms and what they're telling me and what I observe and me getting to know the patient. But do not just stop it. It might have to get cut up a little bit more. And again, it's person individual, but don't just stop it. I don't know if you have a seizure history. I don't know how high you were at. So can't just say stop at 5 milligrams. Okay, Ryan? Yeah, Camila, what is the dose? Okay, 5 once a day or 5 times a day, Camila? That's what I don't get. Matthew, Real Talk, Mark. Oh, thanks, Dave. Diane, Nicole, can you tell Doc my issue? Doc refused to treat me now. I can't remember what your issue is, Diane. I'll do my best if I can. Ultram is addictive, Camila. It's very addictive. So it has a lower abuse, but so let me say that for anybody that's going to say something. Ultram, tramadol, initially came out, and it was sort of pushed out there. Oh, look, it's a non-addictive pain medication. Wrong. Okay, it has less abuse potential, but there's many people that I've had to get off Ultram, and a few that I've had to switch to subs to get off Ultram. And I have one case where it was, well, yeah, it was out of control. He was genuinely taking it for an issue, and he was just taking way too many. He didn't want to be on anything. I told him subs would probably solve your problem. We got because he had this particular condition. I got him off the Ultram, dropped his anti-anxiety meds. His issue is resolved at 2 milligrams twice a day, and he is back to normal. So Ultram or tramadol isn't the substance of abuse. It has less abuse potential than heroin or morphine or oxys, but it is a substance of abuse. Okay. Ryan, I don't know. I don't know how long you were severe withdrawals. So real bad withdrawals. So I put him back on, and I do this baby dose of 0.125 twice a day. I watch him very closely, and my suspicion is that I'm microdosing it, and my taper is going to take several months, very slow at microdoses. 2 milligrams of Xanax is in some ways not much, in some ways it's enough, and it depends on the patient and how long they've been on it. But not even just that. Like I said, this kid was on his Klonopin a very short period of time, and he suffered from severe withdrawals that were just driving him crazy. And then I took over the case, and now, and we'll do a taper over a year or two, Ryan. But it can be dangerous, and you can have withdrawals, And just because you're on 2 milligrams does not mean that it's going to be easy to come off. Okay. The dose, but if it's low, doesn't mean you're not going to have withdrawals. And also, length of time seems to matter. But I have cases where they were on it a short period of time and they were getting. Diane, remind me. Sorry. A year? I mean, I would even go slower, Ryan. You know, I would go to 0.5 and then 0.25 twice a day to spread it out and even it out in your body throughout the day. And then once a day, I would go pretty slow, Ryan. Okay. Thanks, Coral. If you're barely withdrawing, talk to your doctor and speed a little bit or consider cutting it. But again, I have to be really careful. I don't have enough information. But you know, I would say again, let your symptoms guide you, and hopefully you have a physician that'll work with you. How cool. Corral's in Spain. 4 days. It might be okay, Ryan. But again, be really careful. Oh, yeah, I know that, Ryan. You're on. No, Ryan, I understand you're on lithium. I understand that, but you could still cut it in half. It doesn't matter if it's a lowered dose. For example, I might have someone on Klonopin at 0.25. That's not the lowest dose. You can cut that up into quarters. So you can always cut it up. Oh, Diane, was that long one? Yeah, I was reading it. Thanks, Nicole. How many people are on here? 18, okay. Yes, it's called 2 milligrams. To me, there is no jumping point, but what the patient feels, Ryan. So I try to do it that way, whatever they feel, their clinical response. Diane, we were trying to read your thing. I have my kid today, and a better time to talk is Monday or Tuesday. But if you also can send us your email and your phone number, I will, and then call the office, which the number's around. You can get the number to the office. Sure, Parnish, go ahead. Hey, who's here? How are you? Yeah, testosterone. So if you're on long-term opiates, Daddy asked, can you talk about testosterone and when a man should get a test while on Suboxone? Please, sir. My pleasure. It's pretty simple. Uh, fatigue, sexuality issues, even mood. And the rule of thumb is when you're on long-term opiates, you can have hypogonadism. So a lot of you guys have also been on other opiates and now you've switched to Suboxone. So keep in mind, it's not just Suboxone, it's just being on long-term opiates. And so when you have those symptoms, you should tell your doctor. And again, I'm not an endocrinologist, but they usually can do a little bit of cream on your body. And you know, it really takes care of that issue. So if you have those symptoms of hypogonadism, you can easily get tell your doctor, and they should be able to get a test for you. Does that help, who's here? Somebody in one of the comments, which I'll try to. You're welcome, Uzier. No, don't be scared, Ryan. I didn't say you can't get off of 5 milligrams. I said it fully depends on your symptoms and your clinical state. You can absolutely stop it, but I'm just saying I don't know enough about you, and there are some people that we already know. If you've been doing great cutting down and you're working with your doctor, Ryan, you should be absolutely okay. All I'm saying is it's not a hard and fast answer. You know the answer, and your doctor knows the answer because he knows. And that's all I'm saying, Ryan. So do not be concerned. And I'm not really giving an answer. I'm giving you the way it should be done. And I'm sure your doctor has good control of this. I just wanted to make sure you understand that it's not a hard and fast rule. That's all. It sounds like you're doing great. Okay, good. Coral. Oh, by the way, Uzier, the signs and symptoms are just simply depression, decreased energy, decreased sex drive. Can be, if it goes for a long time, you can get erectile dysfunction, infertility, decreased hair growth on the face and body. Answer for you, Daddy. Okay, Coral. I have been in opiates for 5 years since I have APs. I don't know what APs are. I start quitting in August and end the process in middle February. I am feeling very frustrated, back in pain. Do you think it's normal? I have been on in opiates for 5 years. What is normal? That you're frustrated or the back pain? And you might be a good candidate for things like buprenorphine, Suboxone kind of products. But if I'm not answering the question, ask again, Coral. Hitman. Tell me what you mean, Hitman. Methadone 10 milligrams versus liquid. The oral, they're both oral, and oral methadone, all kinds of facilities. I do all kinds of things. In fact, I'll tell you guys a little bit. I run a sober living that's friendly to medication assisted treatment because nowhere else is, and we manage their meds. I also kinship. They basically assist ex-cons get re-entering into society because I don't really too much separate detox, residential in terms of medical and psychological. I also run a medical in Hollywood, and I'm the medical director, executive medical director of that. So I do all kinds of stuff. Yeah, that's funny you said that. AP, yes, of course. So yeah, okay. Let me answer that for Corral. AP is really potentially an autoimmune classification of disorder. Extremely painful. It can be extremely debilitating, both emotionally, mentally, and physically. Now, for issues like something like AP, could be MS, could be RA, could be all kinds of stuff. Okay. For AP, my first question would be to you, and you're in Spain, so I can speak a little more liberally. My first question would be, why are they doing AP? And most people don't understand the patients with autoimmune diseases, whether it's AP, whether it's RA, whatever, they may look normal, but these folks, amongst many other issues, they can be very solid chronic pain patients. In fact, for me, buprenorphine type products are exactly who may potentially benefit from the drug. An AP patient would be a perfect candidate if they are chronic pain patients and all that stuff. I hope that answers your question, Coral. And I don't know what the deal standard of care is right now in Spain. Um, Give me about 1 minute. I'll be right there, guys. Sorry, this is weird. Okay, sorry about that. Assuming that it was the right time for you to get off subs, I don't know if you got off too early, if it was the right time, how long you were on it. But pause, they have been actually measured physiologically up to 6 months. And the suspicion, clinical suspicion, is they can go up to longer than that. And when I say physiologically, we have seen these studies were 30 years ago. We have seen changes on blood pressure, hormones, EKG, pulse, even EKG, up to 6 month point. Now, again, the clinical suspicion at that time and even now is that they can potentially go on longer. In your particular, how long you were on subs, what was the issue before, if you have any predisposing dopamine and substance abuse issues, but they can go on for many months and they can be subtle, right? Maybe it'll take a while for your sleep to adjust. But having said all of that, if you're at the place where it's time to do this, and if you have any symptoms, Blackbeard, let me tell you this. If you have any issues, and again, hopefully you have a physician that's really following this closely, every single day will get better and it'll be going up and you'll have little ups and downs, but every single day gets better. Okay? Hope that helped. Hi, Alicia. Nice to see you. IOP, intensive outpatient treatment. It's for, in the industry, they have levels of care, detox, and that's consists of 3 up to 9 hours a week of group sessions, individual sessions, and I also throw in medical care with that. So that's what that is. What's buffering? And tell me, I'm missing something here. Okay, where are we? God. I'm trying here to catch up. Do I need to get Hunter in to fix the buffering? Hitman, you are not substituting one for another. I'm more of a fan of subs for most people. It's a wonderful drug. You're not trading one addiction for another, and I'll tell you what. Number one, the patient should be told that this stuff is highly addictive, but you already have the addiction, right? So, but what does methadone do? Because of the fact that it's long acting, and because of the fact that it's a very slow rise in your blood level, so it's difficult to get that rapid rush, okay? It's a great substitute rise, so you shouldn't be building more receptors and needing more, okay? And in an ideal situation, if you're using methadone correctly, you should be able to get back to your life and live a normal life and eventually get off methadone. That's putting it very short and simple. It is absolutely not replacing one addiction for another. Methadone can be but the idea that it's replacing one drug for another is something that I'm very much an advocate of. I sort of wave the flag to argue against that point. Okay. Yes, Jack. That's funny. Ryan picked that up. Man, I haven't even set up my library in here. Um, just so everyone knows, um, the World Health Organization doesn't even call it medication assisted treatment. They call it something like they call it the treatment, and any therapies, therapy assisted treatment. Just now in the U.S., SAMHSA and all those guys, it's no longer supposed to be called medication assisted treatment. I'm telling you guys, you might be the first ones out there that know this. Most people know this. It's called medication for addiction, which is, let me tell you why they're doing this. Body this and use it in your kind of like parade out there, that medication assisted treatment. It's okay. It's called medication for addiction because and here's their reasoning, and they're very right. We don't say medication or insulin assisted treatment for diabetes, right? We don't say Coumadin assisted treatment for atrial fibrillation. And so, in terms of the way they're trying to project this, is that this is the first line therapy for most people. Even if you choose not to go this route, this is what the first line clinical therapy is. So it's not appropriate to call it assisted treatment. So I love that, Ryan. Thanks. What's wrong, Hitman? I don't understand. Misty. Yes, Misty is on Coral. Coral, I hope that helps. And I'm a big fan of, because what you suffer from is autoimmune. I hope it's well controlled. I don't know where you're at with it, but I do have a lot of other conditions just because of my past life. Uh, oh, I didn't know H Daddy has the same thing. Yep. So H Daddy, same issue. Great. Thank you for sharing that, H Daddy. It takes a lot for all of you guys to share your personal stuff on here, and I appreciate it. And please understand, I try to be cautious with my answers because I don't want to give medical advice in that way here, but more like medical education. Parrish, I don't know what city you live in or in California. I take care of a lot of these cases. Again, I don't know your particular case, but this is the kind of situation where I try to educate the pain doctors and the patients. Usually, I get them when it's too late and I have to make the transition to a buprenorphine Suboxone product. If if I had an issue with chronic back pain secondary to multiple failed back surgeries, and I had to go to an opiate type of medication, the first thing I would look at is getting on something like Suboxone. That's my general answer about your issue. And I would find a practitioner that's not just comfortable with that, but knows how to manage it. If it works, which it usually does, you will avoid a lot of pitfalls, Parish. That's my thought on that. Wow, so many great thoughts and comments. Oh, is my video still doing that buffering thing? If it is, I'll get Hunter, my nephew, in here. Tell me if it is. Rachel, God, I know you from somewhere, Rachel. Yeah, I think so, Daddy. It's the buffering issue for that reason. Uh, so Jexy put, I think calling it medication, it's another move that I'm very happy about. For years, I've been also advocating they should take out the term detox for these programs that have detox. In my programs, I never call it detox. And I actually called it essentially what they've switched it up to now. It shouldn't be called detox. That implies beginning and an end, and you're done. And you're not, what does that mean? You clean, I mean, is it a liver detox from crappy food? Addiction is a disease of the brain. It's not a disease where you got heroin in your body. So what does detox mean? Uh, and it's called now something like medication assisted withdrawals or medical assisted withdrawals, which most of them don't do medical. So it's another one, Jexy, and I'm going to start using the term medication for addiction. Rachel. Yep, that's right, Rachel. Am I taking new patients? I think so. Diane. Yeah, there's some discussion going on between dependence and addiction. I don't need but my blood pressure medication, and I will have a physiological response if I stop it. But Pia, I want everyone to keep in mind when you go over to methadone or Suboxone, it's not like you walk off the street and get yourself hooked on Suboxone or methadone. You already have that issue. So just something for you guys to, those of you that still really wonder about it. Ryan, I would love to call you. I'm going to be honest with you. Uh, I am so overwhelmingly busy. You're going to have to get a hold of me, kid. I'm sorry, I don't know how old you are, but I call a lot of people kid. The medical office is here. That's the medical office number I put up, and then there's the IOP number 1-800 that you can call, and I don't know that number, but it's just I don't want to promise something. I'm buried. You can get a hold of me. It's not a problem, and you can. I'll give you some advice, but don't panic. I hope I didn't make you panic. Okay. Uh, what is my email? I don't know. Uh, Again, I have about 60,000 emails in my email box, but the medical office email is Hunter. Is that what it is? Okay. Dr.B at Zephyr Medical Group.org. Oh yeah. So you got a better shot at sending that an email. My own personal email boxes have about 60,000, Ryan. I think I'm losing hundreds of thousands of dollars out there. So I suck. Uh, I don't. Someone might be on a Suboxone for many years, and I would, yeah, that one. But I do see him as sober, absolutely. Okay, Diane, thanks. Uh, 7 and sharp instead of dull. Why are you getting the infusion? What's the? I'm presuming it's autoimmune. And new languages always they keep bringing stuff up, and it's a topic I've been. So for years, I'll give you another piece. I don't use the term dirty urine or I just or clean or dirty urine. I don't use that term. I use positive or negative. Take away any stigma that has to do with addiction. And I try not to even use that word. With you guys, I do, but it's just easy. But uh, I call it many other things. But so one of those things is urine toxicology. I never use the term dirty or clean. We should, especially the professionals, we should use positive or negative. Jaxie's a badass. I gave you the email, Ryan. Coral, now my rheumatologist has controlled a lot of my disease, but has taken longer than usual. I can relate to what you said to immune disease. I was feeling much better and I decided with my GP to quit. I understand, and that's okay. So also talk to your GP about, again, in fact, autoimmune diseases are exactly in the way that I'm correctly and nicely so. Relapsing, remitting, and you can have long-term. The case with your autoimmune disease, always keep buprenorphine in mind for the need if the need arises for pain management. Okay. Exactly, Lucia. Words do matter. They do form concepts in people's brains, which can confuse them or lead them to incorrect logic. I couldn't said it better myself. Uh, Hi, Jexy. Yeah, sure. Um, Alicia says, my partner has been home since 1/22, 2020 from work due to her body in constant pain. The doctors aren't sure what it is, but are assuming lupus or autoimmune disease. Uh, any suggestions? Well, Alicia, first I would want the diagnosis before suggesting. And I don't know where you're living, but uh, I'm assuming if we're talking, if your partner is a female, and the only reason I ask is because it depends on the disease, greater predisposition if you're male or female. But first, you want to have your diagnosis, then consider pain and pain management. Um, so that's what and I don't know how long they've been working up the autoimmune thing. It shouldn't take that long. I assume they just recently started. Uh, there's no place, I just read pretty much every day, and sometimes it comes in an article in New England Journal of Medicine. I read updates from SAMHSA or American Society of Addiction Medicine. It's all just in my head because I read this stuff and I'm reading, but I'll look into it. Okay, Jexy, I'll help you out with that. Okay. Uh, Misty. Oh yes, Misty. I won't say it. She said it. She is my patient. Uh, Cheeto, I don't understand. Help me out. Tell me you're not saying these guys are on Suboxone for money. And a lot of people say that, and I'm happy to explain that comment to you guys. Uh, we are all here to support you. We are. Caitlin, hey, Caitlin, hello. Super. Hi, doctor. I'm from Spain. Wow, we got a couple of people from Spain. I'm getting problems with weed. Is it normal? My headache, it's brutal. You mean after smoking weed, you're getting the headache? Just tell me that and I'll answer your question. Uh, Thanks, Nicole. Okay, I'm going to give you guys thanks, Jexy. And this is G. That's what I call him, G. So my nephew's watching him right now. But thank you, Jexy. When do people need to start coming off Suboxone? Classic question, Rachel. And the answer is when it. So now I always but when you start someone on methadone, you should also tell them the same thing. Even though the federal requirements are they have to get off at some point. Rachel, here's the thing with subs, and the time to consider coming off of it is when you've been on it long enough, given whatever your circumstances, where the other issues that are markers of your addictive behavior, going to work, thinking about drugs, you have your shit together and building your life the right way. You show up, you're not thinking like a drug addict. Let me put it that way, okay? And you're just living and you're just taking this medication, okay? I think that is a good marker if you want to and there's no other issues to have the discussion to come off of it. So the next question that it begs is, well, when does that usually take? We actually don't have what's called validated scientific data to know what that is. And I'll even add something more. I'm starting to see and I just worked on a paper with, we just submitted a paper to a really world famous anesthesia journal about all the remarkable things Suboxone does, and it's probably going to get published. But it hits the NMDA receptors in the spinal cord, which my colleague in the field had suspected that, and I had the same suspicion, and I treat ketamine use with that too. And so we also know that it really helps with certain types of severe depression. So some of these patients may be having some of these issues, and it might not be appropriate to ever get them off subs. You can lower it as much as you want, but it may be that you have to be on it for quite a long time. Having said that, I advise, please don't fret. That probably isn't many of you. But also, if you do have to be on it that long, question is very natural given Suboxone, the way we look at it as a culture, as a society. But, I ask all of you this, and you guys are, pretty good Suboxone supporters. People usually, when they get started on blood pressure medication, most of them, some do, but most of them don't necessarily ask, how long do I have to be on this? They assume quite a long time. And so subs is a different thing. It's a different animal. But why is it okay to have to be on it a long time? It's because the risk and benefit adds up the right way. And that's my answer there. And I hope that helps there, Rachel. Yeah, RA. Freya, I thought it was RA. I have many RA patients that I transitioned from opiates to buprenorphine. I don't know your particular case, but oh, thanks, Caitlin. Hi, how are you? I don't know your particular case, Freya. I think you said you're in Spain. I think they're a little bit more progressive in their approach to buprenorphine, but it is a wonderful alternative and really should be first line for painful RA type of issues. So please talk to your physician about that. I'm a big fan of it for those kinds of things and many other things. Jexy is really stuck on that language change. Jexy, you probably don't know, but I find that fantastic too, because my background is not medicine. It's linguistics, philosophy of language, and mathematics. Most people don't know that, but you repeated that so many times. My background is in those areas, and at Berkeley. Uh, Freya. Oh, okay, Freya. So you have quite a bit of disease process that's really exacerbated. Yes, please have that talk with your doctor. Sorry, guys, I'm trying to catch up. Sumista, all this, Sumista, have you ever heard of anyone's recovery story of never using opiates again after ibogaine? So, anecdotal, okay? And what do I mean by that? There's a regular term anecdotal, which means, you don't give too much stock to it. But in the evidence of science, clinical medicine, we also call case histories anecdotal because that tells you nothing actually for a lot of statistical reasons. But I've never seen anyone. I have done some research to it. And although I think there may be potential therapeutic benefits there, it's a far ways from saying go take some and you're going to be cured. Hope that helps. Oh, thanks, Rachel. I'm glad I came in here too. I'm a chronic pain. Lori, hi. I'm a chronic pain patient. My pain doc decided to use Belbuca to treat me. This is my first attempt at long-term pain control. Is this a hard med to come off of? I have no addiction issues. That's great. I mean, not that you don't have any addiction medication to start you off. I wonder why guys use Belbuca. Look something up here. It always trips me out. It's a good medication. Yeah. Yeah, I don't know where uses that. I have never used it. So, Lori, so just so you know, starting you on Belbuca is essentially saying this to you. Okay? So Belbuca, just like this medication we're all talking about here, is in the class of drugs of opiates. But within, so therefore, they can create, I don't want to use the term addiction, they can at the very least create physiological dependence. What is wonderful about Belbuca and choosing that as the first thing they use? Number one, he probably made the decision that your pain is substantial enough that you got to go up to the opiate category. If a person has to go to the opiate category, the medication class within that category that I would use is something like Belbuca. Why? Yes, you will build a physiological dependence because it's an opiate, but it is extremely unlikely that you'll abuse it or become an addict because it has, as I've talked about in different videos, it has a ceiling. And Belbuca, by the way, is the same as Suboxone for all intents and purposes. It has a ceiling effect. You can't overdose on it. Minimal euphoric effect after you get used to it. So if you're on a high enough dose and you just stopped it, yes, you can very potentially feel the physical withdrawals, Lori. But yes, I hope that creates some understanding for you with that. Yes, please give me a thumbs up or something, guys. Thanks, Nicole. Oh, Freya, you're in Washington State? Oh, yeah. Come down and see me if you don't like the doctor. I just actually have a patient coming all the way from Hawaii in the middle of COVID. Thank you, Diana. Douglas. If a person is on 100 milligrams of OxyContin, or 800 milligrams? Can Suboxone work for the higher amount? Like, is there an amount that's so high that, no, Douglas, no. What I have seen, Douglas's question is if you're on a super opiate dose, is there an amount that is too much for Suboxone to work? And the answer is no. But I will say this, those that have been on high doses for long periods of time, there are certain mechanisms, and I suspect it's the frontal cortex versus the midbrain, that the usual transition for me takes anywhere from an hour to 3 or 4 hours. Some of these patients, it takes 2 to 3 days for them to transition. And it's very interesting, Douglas, when I see that. I don't think the pain or the withdrawal cravings or the withdrawal symptoms are really there. I think the frontal cortex is so used to that opiate, it almost can't believe that all those receptors are full without the euphoria. And I've seen that. I have some patients that fly into town and stay at the hotels, and there's a kind of like higher end patients, and they just want a privacy and a fancy hotel room, and they've been on opiates for years. And I've seen that a couple of times. I hope that helps, Douglas. Guys, I have to go. Bye, Jose. It was nice to see you. Go enjoy the guitar. Good to see you. Green-eyed cat. I remember Green-eyed cat. Just one question. Do Norspan pain patches have buprenorphine in them, and do they double as a mild anxiety med? Norspan, is that, do you mean, what is the name for Butrans? Is that what you mean? Let me see if there's such a thing as Norspan. Maybe I don't know it. Oh, there is something. All right, let me see what it is. I don't even know what this is. It's a narcotic, but let's see. Thank you. I just, let me see what's in there. Oh, yeah. Oh, okay. It's the same thing as Butrans. It's a new brand. Give me 1 second here. Sorry, I got to check on my baby. So patches, and the question was, does it have buprenorphine on it? Yes, it does. That's what it is. No, Butrans, Norspan, it's all the same thing. And here is the thing you should know about those. So it's funny because Suboxone is not indicated for pain and are, okay? And they're the same drug. But what is nice about it in a chronic pain patient? The nice thing about it is that you put, what I don't like about the patches is I have less control about changing the dosing than I do with the old version. Okay, I hope that helps. Green-eyed cat, Freya, bye-bye. David Yerman. Huh. Does opiate tapering make the withdrawals less intense? Yes, it should. Tapering versus coming right off, I presume that's the question. Max, Dr. B, please go into details on buprenorphine effects on testosterone. I've read contradictory studies on this, some saying large effects, others saying nil effects. Across the spectrum, Max, it's let me put the question the right way. It's not buprenorphine, any long-term opiates. The data is very, most of the time, it's very, very, and this has to do with the hypothalamus axis, okay? But most of the time, very easily fixed. You get a free testosterone level in the morning, and they can use a little testosterone cream. Now, whether it's nil or a lot, severe, it's for the most part lower to mid range. Having said that, there's always cases of extreme, and the risk is not such a risk unless if someone has endocrine issues. The risk is not so great and clinically significant that one wouldn't start this medication. If there are issues and endocrine issues, I would talk to your physician and the endocrinologist. Okay, so the data, it's pretty much stable. Yes, there's data, and I can talk about this some other time about the differences in data that you see studies, but that's the truth of the matter. It's there. You need to look for it. Anybody on chronic opiates, it needs to be evaluated, and it happens enough. I mean, it happens regularly. You know, in fact, withdrawals, there's no correlation of withdrawals with amount of use. How bad your withdrawals, let me put it this way. If you suddenly stop, I know we're talking about tapering versus suddenly stopping. When you suddenly stop, how bad your withdrawal is has nothing to do with what your doses of use are. We know this. There's no necessarily no correlation, okay? Yes, Douglas, you can come see me, and you can. I have actually have patients from all over the country that come and see me right now. Let me see what this is. Here's a question. Wait, someone asked something about something I didn't know. Give me 1 second, guys. Let me see what this is. Okay. Pain patch. Okay, let me, what am I? Isn't that the same case? Okay. What do you think of Plexia use for pain? Holly, you know what? I have to actually, so Plexia has a norepinephrine, and I'm not going to answer you because I don't have enough scientific background. Once I look it up and do some reading. I do know the medication, but I would be shooting in the dark if I answer you, and I don't like to give you BS answer. But I'll look it up, Holly, and reach out and we'll answer. Douglas, okay. How long does Suboxone stay in your system if you haven't used it in a few days? Depends on your kidneys, but It should be out 5-6 days at the longest. Okay. Uh, David, thanks, Max. You guys are too fast. Uh, Freya. Oh, my baby. Yeah, he's pretty cool. Let's see. Ah, I'll give you guys a quick peek. Hey, Hunter. I'll show you. Oh, I don't even have a thing. Um, okay. Uh, leave us for good, okay? Yes, Caitlin, I chose to go cold turkey off the opiates due to poor treatment by new pharmacy. It was hell now with therapy stopped in quarantine. I am hurting on so many levels. Freya, where are you at in Washington? You got to get down here. In fact, I have 4 patients up in Washington that I actually treated, clean, and sent out. 2 of them, one is actually, you can see him in the paper. They did a big thing on him. He had been in 35 treatment centers, and I talk to him once or twice a week still. I call him kid. And the other guy, same thing. But Diane Zimmerman, Nicole is awesome. She's kind of a badass too. Thanks, Max. David, we're talking about subs. Now you're talking about Xanax. Fast taper depends on the patient. And I always I really do my. How do you feel about kratom? My doctor hasn't answered the phone in a month, and I have about 2 weeks supply left of Suboxone, and I refuse to go to the streets because going on the streets is a trigger. Caitlin, I can't remember. Weren't you going to come see me? No, don't get on kratom. I've made some videos about it. I can't remember where you're at, Caitlin, but maybe you should get a hold of us. No, don't get on kratom. Yes, it does work on opiate receptors, David, but that's not the issue. There's a lot of other things about kratom. I'm really trying to avoid discussing it right here, but it also can act as a stimulant. But it's you don't want to get on kratom. Douglas. Damn, hour and a half. Let me try and finish these questions. David, where in the heck do you live? Live. Dwight, addict named Dwight, coming up on 3 years. That's a 3 year time. Dwight, 3 years is a long time, and that's wonderful, and congratulations. Number one, the support community that we have, and a lot of it is Nicole's channel. She's Real Talk Recovery. She is amazing and always there, and you can go on her channel, and she is a pro and natural at this kind of stuff. She should be a case manager. And all of these guys here, a lot of them are Real Talk Recovery, Dwight. I don't know your particular circumstances. I don't know the drugs and what are the triggers, but what everybody that you see in here, these are all rock stars. And the first place to go to get plugged in, Dwight, is please hook up with Real Talk Recovery, Nicole's channel. Everyone here, including Nicole, are a wonderful source of support and dealing with issues like this trigger coming up on us. Caitlin, I'm worried about you. I hope you don't hit the streets. I almost want to reach out and grab you from Florida. What the heck? Maybe you should give us a call. Yeah, we got to get you in to see a doctor out there. We try to help as many as we can, guys. Oh, you did, Diane? Okay. Please call us tomorrow. And we're going through some transitions here in the office. Uh, but we'll hopefully tomorrow. Okay, Diane? No, hopeless. There's no new research on the niacin sauna detox. And my thoughts are, I don't think it works. Yes, listen to Rachel, okay? Caitlin, don't do, uh, I mean, we'll even help you try and find a new doctor. I don't know. I want to reach out to all of you and help out, but my time is just so insanely crunched. Okay. Great, Dwight. And I think that's badass that you have this many years. Oh, good, 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 Nicole. Yeah, everyone is a rock star here. Uh, Let me see, Nicole. I'm trying to go through everyone's questions. Uh, yeah, the baby was probably yelling at me. I think we're pretty much um, done. I do want to say one last thing here. Somebody asked me about. I don't recall what it's called. It's the same medication that's for detox. It is. It is the same family as clonidine. Wow, Misty. Yeah, I do know you have 9.5 months. I thought that. Yeah. No, not propanolol. It's the same family as clonidine. Forgot the trade name for it. Somebody on the channel, somebody on one of the YouTube things was saying, "Hey, this is the best thing out there," and I just want to caution you guys about that. Let me see if I can look it up. I forgot the name of it because. Uh, Give me 1 second. They sort of tout it as I just want to. There's a great teaching point for you guys to be aware of. God, I can't find it. Let me see if anyone. Uh, Thanks, Nicole. Uh, Holly, that's badass. Okay, Freya. Chris, I'm sorry I missed your. Depends, Chris. It depends how slow you do the taper. Make sure your doctor does it well. Okay, there's something I wanted to say, which I'll say next time. I've had you on here, guys, on here a long time. Nicole, should I end it? Can I do that? You guys have been wonderful as always. I hope I answered some of your questions. And uh, and yeah, tell me if I can go, Nicole. Thanks, Nicole. Thanks, Danielle. I hope I answered you guys' questions. You're welcome, Dwight. Yeah, I wish you the best of luck. I think you're going to do great. Okay, Nicole, we can do it then. Bye, Freya. I wish you luck. Misty, I'll see you soon. Mark, much love out to you as always. Sorry, guys, I'm blind. Okay, Nicole. Bye, Diane. I'll talk to you soon. Holly, David, I hear him screaming. Thanks, Nicole, for helping me out. You're awesome. Coral, good luck, okay? Send me some more people from Spain. I want to go out there and visit one day and eat some of that awesome food. Bye, guys. Thank you. Bye. Hunter, I think it went well.